Thanks, Andrew. Good day, everyone. And it's our pleasure to kick off this virtual journal club for WADEM. We look forward for more and more activities where all scientists and interested in research and updates from all over the world about this pandemic in general and overall disaster and emergency management specialties. So we are proud to have the president of WADEM, Dr. Gregory Ciottone, as the first presentation for this journal club. He, in addition to the WADEM presidency, he is also an associate professor of emergency medicine at Harvard Medical School, and I'm proud to be one of his mentees. And we would like to hear about his discussion on a randomized trial of hydroxychloroquine as a post-exposure prophylaxis for COVID. This study actually was published at the 3rd of June 2020 at the New England Journal of Medicine. And we know a lot of discussion has been ongoing about the hydroxychloroquine, as well as many interventions with this ongoing challenge of the pandemic of COVID. So without further ado, I would like to hear more. Dr. Greg, you may have the mic, please.
Okay, well, thank you, Anas. Also, thanks to Andrew and Sarah from WADEM for putting this journal club, the inaugural journal club of WADEM in place and going through all the logistics of that. Welcome, everyone. We do appreciate you spending some time with us on this journal club. And what I would like to do is we will go over this paper in journal club fashion, as I'm sure many of you have experienced in both your training and if you have academic positions. We'll analyze the paper a bit. But then what I think we should do is have this paper essentially segue us into a conversation over the idea of research during this pandemic specifically, and how research is conducted in a crisis situation, conducted and then also published. And then maybe we can also broaden the conversation out to any other questions or thoughts that you might have about the COVID-19 pandemic in general. So, in true kind of journal club form, we would really very much like to have this a dialogue and not a lecture or presentation. I will probably spend 20 minutes, maybe or less, just talking about the paper. But then I'd like to open it up to everyone and get some of your thoughts on this. And as I said, research in general. So let's move forward with the paper. I'm assuming you've all had it and had a chance to take a look at it. As Anna said, it was published June 3rd of this year in the New England Journal of Medicine. So their general hypothesis of the paper, as stated by them, is we hypothesized that hydroxychloroquine could potentially be used as post-exposure prophylaxis to prevent symptomatic infection after exposure to COVID-19. Now, make note of that title and make note of that word symptomatic, because we're going to get back to that in a moment. And what they did is they conducted a randomized, double-blind, placebo-controlled trial to evaluate the post-exposure prophylaxis with hydroxychloroquine after exposure to COVID-19. And the way the study was designed, again, so this is a proactive, not a retrospective, but a proactive study, which is always interesting and a great thing to do that we can very rarely do it actually in disaster medicine. But it just makes it that much more of an interesting paper. So what they did is they enrolled adults, so nobody under age 18, in this study. It was based out of the center in Minnesota, but also had co-investigators in Canada. But they used social media to enroll these folks. So that allowed them to actually broaden out their catchment area of study people much further and beyond than the Minnesota or the specific Canadian regions. So they got a broader look across the United States and some in Canada as well. Of this COVID-19 outbreak. And what they did is they looked for people that had household or occupational exposure to someone with confirmed COVID-19 by testing at a distance of less than 6 feet for more than 10 minutes while wearing neither a mask nor an eye shield, and that was considered their high-risk exposure group, or while wearing a mask but no eye shield, which was considered their moderate risk exposure group. Now it's interesting that they would differentiate it that way, in my opinion. Because clearly wearing no mask and no face shield is an exposure that's concerning, especially with household or with close contact within the 6 feet. But then the idea of wearing a face mask and no eye shield, I'm not sure how they came up with that. I don't know, in my mind, how much protection an eye shield gives you beyond a face mask. I don't think anybody knows that, but not to fault it. I just thought it was an interesting way to differentiate between a high risk and a moderate risk exposure. So what they did is, again, through social media, so these were people who were sort of self-volunteering that they have met these conditions. They were aiming for within 4 days of exposure, randomizing the participants to receive either the hydroxychloroquine or placebo. So what they were looking to do essentially was, the objective was to try to get this pharmaceutical intervention, hydroxychloroquine, into patients before the median incubation period that we know today of COVID-19, which may change, of about 5 to 6 days. So they're trying to get the treatment in before that 5 to 6 days, hence the 4-day post-exposure limit. Now, the dosing regimen they use at the hydroxychloroquine is actually quite a high dose. They used, the whole treatment regimen was, they gave 800 milligrams at once, that's 4 tablets at once. Then they gave 600 milligrams 6 to 8 hours later. So within 24 hours, in less than 24 hours, they got 1,400 milligrams. And then they gave 600 milligrams daily for the next 4 days. So the total regimen was 5 days, but this is a high dose. Typical dosing of hydroxychloroquine for its known uses is 400 to 600 milligrams in the first day, usually split up, and then 200 to 400 milligrams a day, also usually split up for the next 4 days. So this is a remarkably or dramatically higher dosing. But again, hydroxychloroquine, as you know, this is a timely article as well, because as you know, here in the U.S., just yesterday, I believe it was, the FDA actually took back its emergency use guideline for hydroxychloroquine and said actually they're not approving it as an emergency use for COVID-19 because they found, based on different studies, that not only is it not effective, but actually may be harmful. So it's actually been backed down, and it's not on that emergency use category. But the reality is that had it been were to be approved for SARS-CoV-2, we actually don't know what the right dosing is. So I say this is a high dose. I'm comparing it to the way hydroxychloroquine is typically used, for malaria prophylaxis, what have you. And not the way it could be used for COVID-19, because we just don't know what the right dose is. Having said that, it's a high dose. So the primary outcome that they were looking for was either confirmed COVID-19 infection, in these participants by testing, or if testing wasn't available, which was the case in most of these illness was compatible with the COVID-19, so like an ILI, right, an influenza-like illness, within 14 days of starting the treatment. So again, an interesting thing, and we'll get into that a little bit later. They did have some secondary outcomes too. I'm not really going to get into much of that because, first of all, it wasn't as rigorous, I think, as the primary outcomes, and I don't also think it's as valuable information or data as the primary outcome data. But the secondary outcomes they looked at were hospitalization for COVID-19, deaths, the incidence of testing positive, the incidence of symptoms, how many discontinued the trial intervention. So there's a number of different things they looked at as secondary outcomes as well. So when you look at the group, there was 821 that were enrolled. 10.7%, I think, of them did not complete the 14-day survey for a number of different reasons. And that was fairly evenly split. There was 46 in the hydroxychloroquine group that didn't continue and 42 in the placebo group. I'm sorry, in the placebo group. And the biggest reason cited for not continuing the treatment was the presence of side effects. Which is interesting when you talk about placebo. But yeah, it was the incidence of side effects. So as they collected the data, now this is getting into a lot of statistics that I don't want to get into too deeply, but essentially they both primary and secondary outcomes, the incidence of COVID-19 disease, were assessed using the Fisher's exact test, which is essentially a statistical significance test. For those participants who the incident of illness was compatible with COVID, had COVID-19 symptoms, they also looked at that again, the median and the interquartile range and assess distributions. They use something called a Cusco Wallis test, which is essentially a rank-based non-parametric test used to determine if there are statistically significant differences between the two groups. But suffice it to say, they used some pretty hard statistics on this data, and the results were that the incidence of new illness they found that was compatible with COVID-19 did not differ significantly between those receiving hydroxychloroquine and those receiving placebo. So, and this was statistically significant. There didn't seem to be a difference at all. Now, some of the things to look at and the more interesting parts of this study is, first of all, healthcare workers accounted for 66.4%, I think, of the participants. So it was a higher number of healthcare workers, so as opposed to household contacts. So not sure there's any significance in that. There may or may not be, but you have to question yourself that, okay, if the people that, the healthcare workers that are being exposed by patients, do these patients have some sort of higher viral load, a more virulent version of the virus because of the fact that they're inpatient? Not sure, but it's something just to think about as we talk about the results. And then again, the adherence to the trial itself differed, like how many people actually took the full regimen of 5 days differed, as we said. And one other piece of it was that, for the most part, the overall percentage of enrolled patients, the breakdown of the enrolled patients was relatively younger than the general population. So the average, I think the median age was 40 years old. So this study, for the most part, didn't include many, if any, people that were in that high-risk group. So, 65, 70, 80 were not, for the most part, well represented in this study, which also brings, into question, some possible issues with the study. Now, again, it's not to say that the authors didn't acknowledge this. They did acknowledge this in their limitations, but it's one thing also to consider that the age group measured here was a little bit lower, lower essentially than your general population. So some of the issues, and again, these were listed as limitations, so give the authors credit. This is not saying that their study is flawed, but these are the limitations of the study. The biggest thing, I think, is this idea of asymptomatic cases not being necessarily picked up because testing was not robust enough. There was not enough testing out there to get all participants tested and therefore confirmed positive or negative, let's say. Which brings, so either the only way you became positive in this study was that you were tested positive or you had symptoms that were ILI, essentially, influenza-like illness. That were then attributed to COVID-19 and you were deemed positive. So this brings to light the idea of, okay, what about those patients who had either very mild disease or asymptomatic disease, which we know there is X percentage of patients out there who get either very, no symptoms at all or very mild symptoms. These might fly under the radar of this. Now, theoretically, that should be equally represented in the two groups, the placebo and the hydroxychloroquine group. But, we're not sure about that. And it just brings to light a limitation of the study that we need to factor in. And then, the idea that because of that, it's theoretically possible that the hydroxychloroquine therapy actually limits, proven infection. Actually, it doesn't limit based on the study proven infection, but theoretically it could prevent or at least convert more serious infection to milder cases, because we just didn't have a chance to measure those mild cases. And that's why when you go back up to their initial study hypothesis, I said to make note of the word symptomatic. And I'll read that again, their initial hypothesis. We hypothesized that hydroxychloroquine could potentially be used as a post-exposure prophylaxis to prevent symptomatic infection after exposure to COVID-19. I think that's true. But again, you have to read that with the eye towards what about asymptomatic infection. Now, one small issue with this paper is, after having said that in the hypothesis, their conclusion is stated as this: this randomized trial did not demonstrate a significant benefit of hydroxychloroquine as post-exposure prophylaxis for COVID-19. Whether pre-exposure prophylaxis will be effective in high-risk populations is a separate question. With trials ongoing, in order to end the pandemic, a reduction of community transmission is needed. So that's their concluding statement. And it doesn't really make note of that that symptomatic piece. It just says that did not demonstrate a significant benefit of hydroxychloroquine as post-exposure prophylaxis for COVID-19. Again, I would argue that that's probably the case. Except, what about these cases that fly under the radar? How many placebo cases, in other words, were there that had asymptomatic or no or mild symptoms that were deemed negative and not positive, or actually in truth negative, which would throw this, the results of this off a little bit. So that's really a breakdown of this paper. We can discuss the points of this paper further if you like. But what I think I'd like to do now is open this up more to a discussion about research and in the time of a pandemic like this, in the time of a crisis, and how that's conducted, how that's reported, and how it's peer reviewed essentially. So as we all know, if you've been following the literature and the news, there's been first of all, in the beginning of this outbreak, there seemed to be, a dearth of research and papers on this at the very beginning. There's not much was coming out. We didn't get a lot of good stuff. And then suddenly, 3 months ago or so, papers were, the journals were being flooded with submissions and papers and research and articles, and a lot of them were editorials and reviews and different things, around COVID-19, truly flooded. And that put a strain on journals. So the point being, we all know, if you've been watching the news, that recently the Lancet had to retract an article. The New England Journal had to do the same. The Lancet article, if I'm remembering it correctly, was actually more important because it was the article, if you recall early on, I don't know, I can't remember exact dates, but somewhere in the February time period, there was a paper that came out of Germany, that came out in the Lancet from Germany, where that essentially pointed to asymptomatic spread. And this suddenly became a big deal because, as we all know, asymptomatic spread versus symptomatic spread is very concerning. If you're walking around with no symptoms, for 2 or 3 days, whatever it is, yet you are able to transmit the disease, that's a big concern. So this paper essentially said it looks like that SARS-CoV-2 could be spread by asymptomatic carriers. And those are carriers that either go on to be, fully asymptomatic or go on to have symptoms, but are just in that asymptomatic period now. Again, a big concern. But you look back at the study, and the reason it was retracted was the study was based on I forgot what it was exactly, a trade show in Germany, where a participant, an attendee from China, a woman, came and went to the trade show, was asymptomatic, left, went back to China, and then, several days, however many days later, all these people became ill, and they contact traced it back to her. However, that she was stating that she was asymptomatic at the time. So the paper gets written, asymptomatic spread is possible. Everybody gets very concerned and nervous. Turns out, when it was investigated further, the study authors actually never personally interviewed the woman from China. And when they did, when others called her, they found out that she said, in fact, yes, she was symptomatic while in Germany. So this throws this idea of asymptomatic spread, into disarray, and hence the retraction. There's been a couple other, retractions as well. There was a paper that was done with, it looked like a database that was compromised and wasn't reporting accurate data. So it brings to light this idea of how do we conduct research during the time of a pandemic or a crisis, especially when you have a novel virus like this one, where there is it's more than just the need to publish and the desire to publish just to better, scientific knowledge, but there's actually potentially a direct effect on saving lives if you can get valid data out as early as possible in the time of a pandemic of a novel virus or whatever it is that you're looking at that we don't have really this information on yet. but at the time of your doing the research and publishing, it's actively killing people. So if you can find something, there is motivation if it's going to be clinically significant, whether it's a vaccine or a therapeutic or whatever it is, to get that out in the press so it can be used. You then balance that or bridge that with peer review and scientific validity. So I don't think anybody would argue that a lot of these papers went through the peer review process quicker than they would normally go through it. And this is the sort of the paradox. This is the dilemma that we all are in right now. And we're seeing it now with therapeutics, hydroxychloroquine. Remdesivir is being tested, and we're seeing some positive things, some not so positive things. But it's all it's still all a little bit nebulous with the therapeutics. We're not quite there yet. I predict we're also going to see it in the coming months with vaccines. So as the vaccines start progressing to human trials, which some of them are, and we're starting to get some data back on that, I think we're going to see the same kind of thing. We're rushing to report, but we really need to make sure that the data that we're reporting is valid, is significant, because we all remember the oath that we took before we became doctors and nurses and other healthcare professionals. This idea of non-maleficence, right? We do not want to do harm. And I think one of the reasons hydroxychloroquine was pulled back quickly was that, and again, I think the jury's out on this. I don't think we're 100% sure about this, but there's some indication it might actually be harmful. And that's certainly not what we want to do. We obviously want these things to be efficacious. We want them to work, because that's a problem in and of itself if we say it works and it doesn't. But we certainly don't want them to be harmful. And I think what we're going to do now is start to see the same kind of thing as vaccines start coming into the spotlight, because they're coming closer and closer to real use as they go through human trials. So I'm gonna kind of be quiet for a minute here and let others talk or give some thoughts and ideas about this. Honestly, I'm not sure what you think, and I don't know also if there's some questions, but I'd love to expand this conversation about research in time of crisis. But also feel free to have a discussion, a conversation about other aspects of COVID-19 and what we're going through now as well. As well as the paper that we just presented. So I'm going to open it up for a moment now and step back.
Yes, many thanks, Greg. We're starting to receive some questions, and I would like to thank you for this excellent presentation. We have seen that it's a quite well-designed study. The randomization, the follow-up was pretty much very high standards, and the concealment was done with the baseline prognostic factors. It's fairly distributed, and the groups were otherwise treated equally. We've seen that even their follow-up, the dropout are only 10%, which is acceptable. So in general, it was a well-designed study, came with, as you mentioned, some of the caveats here and there. Maybe the main one, as you mentioned, the endpoint being defined as having symptoms. Rather, we know many people are discussing the asymptomatic carrier or asymptomatic patients being positive if tested. And a lot of discussion that would be contributing to the widespread of this virus. So that's in mind, but the overall results, it is aligned with hydroxychloroquine being on the shortfall for being any prophylactic post-exposure wise. Maybe, as you mentioned also, I would like to double down about the point of having research during the pandemic. There is the huge pressure on all the researchers and scientists to produce papers, to accept, even as a peer reviewer, accept papers. We need to push the evidence more and more for everyone. We need to have this body of science that will guide the clinicians and the frontliners. But on the other hand, this will the slippery slope of getting away from the usual robust scientific methodology that might hold back some of our progress in the terms of science. But so this is a trade-off that we need to be really careful about how to handle it. The bouncing ball of each one of them, we're having like tides or waves every now and then. there is a tide with this for this direction, and then we're having a retraction, or we're having some other evidence that's contradicting this. So maybe my first question to you, because I recall that you always discuss this point in general, in other topics, about watching the curve or knowing how things will turn out. We usually, with experience, with science, we can predict how things will come out. But this is usually a fair first experience for us. No one have faced a pandemic before. Even for the H1N1, when it was a pandemic in 2009, it wasn't at this magnitude. So how do you say, what are the tools that we need to master or to take care of while we field mind or go through this field mind of the evidence during this pandemic, to take care and make the right choices based on these scientific findings? Because as mentioned, and the first question we're receiving, that we're having wealth of data, how to choose and pick from all of this and then move forward, and then I can give you more questions after that.
So the question is, how do we manage the data that we're receiving, and how do we move forward in this current climate? Is that essentially it?
Yes. Yes.
Yeah, so as you point out, nobody has muscle memory on pandemics. Now, we've experienced pandemics. We experience a pandemic every year with seasonal influenza, but of course it's not. Though people do die, and there's some worse years than others. Seasonal influenza, goes around the world every year. So we do have that, in a sense, that experience, but we don't really have experience of very significant pandemics like 1918, 1968. None of us have muscle memory in 1918 pandemic, and of course, very few of us have any muscle memory in the 1968 Hong Kong flu pandemic. So, it's really the data that we can read about, and some of the historical precedent that we've seen and are able to access. But the reality is that the world is entirely different now than it was in 1918 for a number of different reasons, even 1968. Certainly, healthcare is different and better, but we're much more interconnected. Look how quickly this spread around the world. I don't know for sure, but I'm pretty certain the 1918 pandemic did not spread this quickly. But the one thing that we can take from both of those that's fairly concerning is that each one of those. Now, 1918 pandemic infected 500 million people around the world and killed 100 million people in the world. It killed 1 million people in the United States. The 1968 pandemic went and I think was killed. I believe it was 100,000 in the United States. I forgot how many in the world, but it wasn't as bad as the 1918 pandemic. But in both cases, both 1918 and 1968, there was a second surge that was bigger and worse than the first surge. So that is of concern. Now, in 1918, there were no vaccines, but there were social distancing strategies being done. And then a very famous study between St. Louis and Philadelphia, where St. Louis implemented social distancing strategies, lockdown essentially, within 1 day of the first case arriving in St. Louis, whereas Philadelphia didn't lock down until about 11 days after they had their first case, and they actually had a citywide parade in between. And those two curves that we all see, often, the blunting the curve graph that has one curve that goes straight up and the other curve that goes on a more, modest climb, and the second curve doesn't go over that kind of overwhelming the healthcare situation, healthcare capabilities. That curve that you see, the typical one being used, is actually data plotted from Philadelphia and St. Louis. So the big curve, the steep curve that goes well over hospital capability line, is Philadelphia, with late lockdown strategies being implemented, and the other line was St. Louis, with a much more manageable outbreak. So we do have precedent, we do have data from that. Now, in 1968, there was a vaccine available, but it was estimated, I think, 86% of the population had actually had the vaccine at that point. And also, social distancing strategies, interestingly, were not really implemented very much at all. In fact, Woodstock happened in the midst of the 1968 pandemic, believe it or not. So, this whole idea of locking down and no mass gatherings, et cetera, really wasn't adhered to in 1968. Yet we can look at that data as well. You can also look at, how well a vaccine works, because there's some data out of 1968 that showed it was a town in Washington, in Michigan, that I'm escaping now the name of the town, but this town had almost all of its children vaccinated, and then the town next to it had almost none of its children vaccinated. And of course, the non-vaccinated town did much worse with the influenza, predictably. So there is, while these are uncharted waters, there is some data we can take back from past experience. Having said that, we are in uncharted waters, no question, for all the reasons we just listed. It's a novel virus. This kind of pandemic, with the R naught value, the transmissibility of about 2.6, which is, it's really 0.1 to 0.2%. I'm sorry, it's about 1.6 or 7 to 2 or so of influenza, so it's a little bit more infectious than influenza. SARS is 10%, so it's not as infectious as SARS. Measles and mumps are like much higher, 14 or 18%. So and then the case fatality rate is a little bit higher now with this as well. Typical seasonal influenza is 0.1 to 0.2% case fatality rate. COVID-19 seems to be about, depending on where you are, 1.1 to about 7.2% case fatality rate. Again, not like let's say Ebola, which is 50 to 70% case fatality rate, or rabies, which is almost 100% case fatality rate. And I always say, we better learn these lessons soon about the early, first of all, containment. The most important first step of making a local outbreak, preventing it from becoming an epidemic or a pandemic, is early containment. If we don't learn this about early containment, and then if we don't have early containment, really early triggering of this lockdown and social distancing strategies, and if we ever have a new virus that emerges that has the R naught value of let's say a SARS, or even worse, measles or mumps, so very, very highly contagious, and a case fatality rate of an Ebola or rabies, I think we would be, not only would our healthcare systems be absolutely decimated, but we would actually be threatened, I think, as a species. That would be a tremendously devastating pandemic if it were allowed to escape and become a pandemic. So having said all that, we're in uncharted waters now, and what we're trying to do is get ourselves to the point where we either have a vaccine or herd immunity, or therapeutics, or all the above. So the way we get herd immunity is two ways. One is we have a vaccine. The other is assuming there's some immunity conveyed by this virus, which we all think there is. We haven't proven it yet, but we think it is. And then also assuming it extends for at least 6 months to a year. We hope it does. That's one way to achieve herd immunity. The other way is with a vaccine. And we've shown with different calculations that if we can achieve a herd immunity of 60% of the population, then this pandemic will start going away. The virus won't go away, but the pandemic will go away, and it'll fly under the radar screen, much like seasonal influenza does. So we're either trying to bridge to that or effective therapeutics. And the effective therapeutics are things like, remdesivir or some of these others that are truly effective. We can actually treat it. So some viruses, we have vaccines, seasonal, influenza, you name it, rabies. Some viruses, we don't have vaccines, but we have good therapeutics. HIV is a primary case of that. HIV has been around for 50 years, no vaccine, but we have therapeutics and treat it. So it's very much under control. So we're trying to get ourselves to that point. And the way we do that until we get vaccines and or therapeutics is with these what are called non-pharmaceutical interventions, or NPIs. That's the social distancing, that's the lockdown. So here's where data becomes so important. All these models that we see, you wake up every day and there's a different model, right? These models they're necessary, they are predictive to a certain extent, but they're only as good as the data you put in them. And the problem is that we don't have all accurate data to put into the models to therefore get accurate data coming out. So there's accurate data we put into the models, and then there's some other kind of predictive stuff that we put in the models, and then the model spits out data that shows that, okay, there is going to be a second surge, there's not going to be a second surge, it'll be better with social distancing strategies, worse, all these different models. So the most important thing to answer the question, I think, is we need to make sure that the data that we do get, that we do have, is valid. We want to make sure that the data that we research that we do, the onus is on us as researchers to do valid research programs. The onus is also on the peer review space, the journals, to make sure, I know it's rushed, but make sure they're adequately peer reviewed. And then it's the onus on the rest of us, let's say the public and also other practicing physicians, to make sure that you take the good data and act on it, and dismiss the bad data, or at least understand that it's bad and treat it accordingly. And if we can proceed that way, then we're going to get through this period of time now where, everybody's in that downgrading, downregulating of social distancing strategies period of time, for the most part, not everybody in the world, but most are. And we're trying to figure that out. There is data on how to do social distancing strategies, how to ramp them up, how to lock down, again, Philadelphia, St. Louis, et cetera. But there's very little, if any, data on how to down-regulate them, how to turn them off. And that's where we are now. So we need to make sure that we use the good data to make our informed decisions. And also, we as scientists, we report that good data up the chain to the policymakers so they can make good policy based on good data. And then we dismiss the bad data. That's my long-winded answer to the question, I guess.
Yeah, well, that's pretty interesting. But I'm not sure, maybe it was Cleveland. There was also a third city for the case study that they locked at the beginning, and then under the pressure of the business owners, they opened and they dropped the ball, and then they have the jump in the curve. So also that's something to look into. And maybe that's perhaps we need to take care of, since we're facing or expecting, since there is no vaccine, no treatment, that a second wave. So everyone is thinking about, are we going to face a second wave? And if we do, will the population be able, or will they accept to having another round of these social measures, the lockdown or whatever? So that's something we need to look into, the research about the acceptance of these measures. Are there going to be willingness from the population to go through another hurdle of this, especially with the socioeconomic impact of it? That will be interesting. So I may also have one of the questions from the audience. So it says that I find it difficult to organize research projects during the current pandemic. We do have some very robust data from some metrics we use in our ED, which is military facility with multiple satellite centers, and could potentially use this data as a significant quality improvement project, which could, in theory, have implications for not only our facility, but our Department of Health. Would this be something we could interest a journal in publishing? What do you think, Greg?
Well, I think so. Yes, because one issue that we're raising is, or we're facing is, you heard me say the case fatality rate for COVID-19 is anywhere from 1.1 to 7.2%, depending on where you are. And that's because there are so many factors that variables that factor into those rates. Because every region, every country, every place in the United States, every state, it's almost like we have 50 small countries here in the United States in terms of how we face, or how we're dealing with the COVID-19 crisis. There are so many different variables that include population densities, cultural practices, implementation. When were social distance strategies triggered? How were they triggered? What set of social distancing strategies? How are they downregulated? There are so many variables, and it's really hard to just give this sort of blanket statement that this is the way everywhere in the world that, let's say, social distancing strategies need to be triggered and implemented, and this is the way they need to be downregulated. It's just not possible. So that's why all of the different experiences that the countries and people are having, I think are valuable, are important, because they teach us something different. So, if you have good data that, of interest of what's the situation is where you're from, where you work, what interventions have worked, what haven't worked, how's the trending of cases and testing, and all these different things that we hear about. How is that happening, and what's the data that you're collecting from your region? I think that is valuable. I think it is valuable, and it's of interest to people around the world. I think it is very publishable because, again, the more experience we can get with this virus in these different settings and situations, the more knowledgeable we're going to be about it.
Okay, so the academic part will say yes, but the clinician part of me will throw this follow-up question. So is there any wisdom of holding, because everyone is talking about research, because it's uniqueness of the experience, is there any wisdom of holding back and sitting tight and say, all this is white noise, I'll just hold to the basics, social distancing and support service, support care for the victims? Do you think this approach will hold?
Do you mean the approach in practice and how we practice, or the approach in research and what we report?
For the frontliners, or who are used to do every now and then a couple of research projects. They feel the enthusiasm to have some research products nowadays with this pandemic. But again, as we mentioned, even the journals, they're complaining. We don't need any more COVID related. We need the usual the other diseases.
Yeah, and I think there's a certain amount of truth to that. I think that if you're a frontline worker and you have data and you're interested in publishing, it would actually be better. And there's a caveat to this I'll mention in a minute, but it would actually be better if you did wait a little bit to the point where you have good hard data, and it may be, especially if you're looking at implementation of social distancing strategies, putting them on and turning them off. You're really not going to have the full optics of that data until they've been fully turned off and we're outside of this, so we can look back and see how we did. Again, the Philadelphia and St. Louis model, which was reported on a year or two later. If you're reporting on something like that, you're not actually going to have the full data, which is going to make your study that much more robust until you get on the other side essentially of this pandemic. Now, the caveats to that are, if you're a bench researcher and you're working on therapeutics, or you're working on vaccines, or what have you, that data needs to be reported immediately, because that is very, very crucial and vital to get out into the press and get into other people who are either practicing, into the eyes of other people practicing, or doing their own research so they can modify their own research on therapeutics and vaccines, because that's harder data, and it's more important. If you're doing research on non-pharmaceutical interventions, it's okay to report some of that, but I would argue that you won't have the full breadth of that understanding of that data until, again, we're somewhat on the other side of this pandemic, and you can look back, and then you can look around and say, okay, well, this country did better than that country because of why. Oh, I can see why. So, for instance, if you look now, even though it's middle of the pandemic and all the data's not in yet, if you look at the case rates and let's say the case fatality rates, we found that a good measure for COVID-19 is actually the deaths per million, or deaths per 100,000, let's say. But we find that once you hit 2 deaths per million, that's when your case fatality lines start taking off, start really rising, if they're going to rise at all. And these right now for COVID-19 directly reflect the effectiveness of social distancing strategies. So if you look at some of these graphs, and you see the graphs from the initial outbreak in China, you see from the early outbreak in Italy, you see from New York City, some other places where the graphs really, after 2 deaths per million, really took off almost straight up. But then you compare that to some other graphs, Germany, right, and Czech Republic, and you look at their graphs, and they're very, very low. They are that St. Louis experience, if not even better. And you say to yourself, okay, why is that? Well, again, the data's not all in yet, and I'm just hypothesizing here. It may not be the only reason, but we do know that Germany had, before the pandemic, a relative surplus, of things like ICU beds and ventilators, et cetera. So that helped. We do also know that the Czech Republic implemented a very robust, very good public marketing campaign on the benefits of wearing a mask. And essentially, through public education, they convinced everybody that, you go outside, you got to wear a mask. And everybody did. And it looks like right now, the full data will be in later, but it looks like right now that has successfully really blunted the curve. I mean, really got it to a minuscule level. So there is some data to be had, but it's going to be more complete data. If you're talking about non-pharmaceutical interventions, it'll be more complete data on the other side of this pandemic. Whereas the harder science, the therapeutics and the vaccines, that's data we need to hear about now.
Yeah, I totally hear you. So another question is, my background is disaster medicine, and I find it increasingly difficult to do research studies during disaster scenarios, which are RCT trials, and a large number of studies in disaster medicine have been observational or disruptive. What are your thoughts?
Sorry, I was on mute. Yeah, so I mean, this is the age-old, the problem with disaster medicine research is that it's so hard to do, prospective research, programs or projects on most aspects of disaster medicine, because it's so unpredictable. Now, when you're in the midst of a pandemic like this, as this study that we examined did today, you can do some prospective things, but for the most part, it's pretty tough. So, but it's not undoable. It's doable. Let's put it that way. So it's a matter, I think, of the researcher really thinking out what is the question they're looking to answer, and how best can they answer that question. The easy way to do it is some sort of retrospective meta-analysis, but maybe it's not that much harder to do something that's prospective. Maybe that would be successful, and maybe that would actually give you better data. So I don't have a good answer to that, Anas, but I think that the more that we as a specialty, disaster medicine, the more that we make an effort to make our research as robust and scientifically valid as possible, the better we are going to be as a specialty and as researchers as well.
Okay, I totally hear you. So another question, is it about the utilization of spatial data, the GIS data in such a pandemic? How we can improve our response utilizing this data? Maybe it starts with the lack of these data.
Well, again, I think data has to be scrutinized very carefully. Now, it's difficult, right? The study that I referenced that utilized data from what turned out to be a data set that was probably not accurate, maybe compromised. It's very hard to be able to discern that, as a a kind of frontline worker who's trying to look to the research, look to the literature, to help them in their practice of caring for these patients. It's super hard, but again, it's also very hard because especially when they're being reported in very reputable journals. I mean, the Lancet, New England Journal. You don't get much better than that, and it's hard to not trust something coming out of that. But again, I think it's a matter of just utilizing a scrutinizing eye towards any data that you see, taking a good look at it before, and making sure that in your mind you're comfortable that this seems to be valid, this seems to be a real measure that I can use, before you implement it in your clinical practice or in what you do for in response to this crisis. It's just a matter of trying to scrutinize the data. I think there's not much more I can really, not much more advice I can give on that, I don't think.
Yeah. Well, it's extended much more than we expected. I thank all the audience for their question and participation, and big thanks to Dr. Ciottone for his presentation and valuable inputs. Again, another appreciation for the team, the support team, Andrew and Sarah. So we can conclude this with a final note, or we shall conclude. Doctor?
Well, yeah. Again, I'd just like to thank you on us for having to sort of doing this as a first inaugural journal club. Thank you again, Andrew, Sarah, and thanks to WADEM too for wanting to take this step. I think it's a good step. Thank you to everybody in the audience for taking the time to spend with us here. And look to WADEM for more information and more events like this. Also, if you take a look at our website, you'll see there's a dedicated COVID-19 section. You'll find podcasts, I think, on interesting topics. You'll find other webinars as well, COVID-19 as well as other topics. So I hope you look towards us as a source of information. And thank you to everyone for your support.
Yes, so this will be recorded and uploaded in the website of WADEM in the resources part. And we hope to hold this journal club monthly. So please continue to give us some more ideas or for any topics from the audience. Or any nomination for presenters, and please spread the message, and please communicate, and I wish everyone a lovely rest of the day.